Hello, good evening, everyone, and welcome to yet another presentation on medical coding buddies. For those who are joining us, um, please come on in, and I will give it here a second for everything to go live across all the different platforms. Welcome to Medical Coding Buddies, yet another series of educational material that we're going to be doing tonight. We're going to be covering the 3M encoder, and we have some participants who join us to do some live training, tutorial training, and that's what the plan is for tonight. Before I do that, though, however, I want to take some time to highlight some information that is going on in the industry that you need to know about. There's some new information coming out that you need to know about, and I want to take some time to go over those. First of all, the first information I want to go over is AHIMA. AHIMA has made some changes in regards to um, testing and so I'm going to share my screen with you. Hopefully you guys can see that. Let's see if we can get that up there. But basically what's happening is that it says that as COVID-19 continue to spread globally, our highest priority is your health and welfare. AHIMA is taking the following proactive measures, and we will continue to keep you updated as changes arise. And that this is as of 5/5/2020. So May 5th, this came out. Person View test centers are now open for AHIMA certifications. So you still have to go in and do your test at the Person View Center. And from what I understand is that they're going to be making accommodations for you if you would like that to happen. Um, so if you need special accommodations as far as your testing is concerned, that can be arranged via a Person View. So once you get your authorization to test and you know where you're going to be testing at, what you need to do is contact your testing center directly and make those arrangements. Now, you can also contact AHIMA and request additional information, and also to get special requests down for. There's some folks who may have special needs, and so therefore AHIMA and Person View can accommodate you at that point in time. Okay, so the next thing I want to highlight for you today is going to be the new diagnostic measures that we're pretty much going through when it comes to COVID-19. So there's some new things that came down the pipe that I need you to be aware of. And so I'm going to share my screen with you guys so you can see exactly what I'm talking about. Um, and so basically that there's some new diagnosis codes, right? And everybody's aware of the UO 7.1 that everyone is now utilizing for COVID-19. These may be used for discharges date as of April 1st in 2020 and beyond. So anything prior to April 1st, 2020, we were utilizing a B code for those claims, but we're well beyond that now, so I don't think we need to highlight that. I'm pretty much sure you're coding April 1st, 2020 claims and beyond. So, but UO 7.1 is the diagnostic code of choice that everyone is now utilizing for coding purposes. Now, can the UO 7.1 be used as a secondary code? And the answer from AHIMA is that, not AHIMA, but just AHIMA and CDC alike, when COVID-19 meets the definition of a principal or listed diagnosis code, code UO 7.1, COVID-19 should be sequenced first, followed by the appropriate codes for associated manifestations, except in the case of obstetric patients. So, however, if COVID-19 does not meet the definition of principal diagnosis, example, when it develops after manifestation, then code UO 7.1 should be utilized as a secondary in those kind of situations. So you're going to look at your medical record to gain that insight as to what should be for that particular scenario. So it's very important to know in pretty much majority of not 100% of your case situations, your 7.1 should be your principal diagnosis of choice, should be. Are there additional new codes to identify other situations specific to COVID-19? And the answer is no. At the present time, there are no other COVID-19 related ICD-10 codes. However, the Center for Disease Control and Prevention Center for Health Statistics, U.S. agency responsible for maintaining ICD-10-CM in the U.S. is monitoring the situation. The all-cycle release of code UO 7.1 COVID-19 is unprecedented. It's the first time that I've ever seen this happen because of the way it was rolled out. It was pretty sudden and drastic, and it had to be done. Now, some in the industry are aware of a code UO 7.2, and here is a highlight on that. We have been told that the World Health Organization has approved an emergency code of UO 7.2, and basically stands for COVID-19 virus not identified. And so it's asking, is code UO 7.2 okay to use in the United States? And the answer for that is the HIPAA code set standard for diagnosis coding in the US is ICD-10-CM, not ICD-10. We utilize a clinical modification system. So as shown in April 1st, 2020 addenda on the CDC website, the only new code being implemented in the US for COVID-19 is UO 7.1. Then he asks, how should we code cases related to COVID-19 prior to April 1st? Well, prior to April 1st, it says that please refer to the supplemental material in the ICD-10 official guidelines for coding encoders prior to April 1st. But I don't think you guys should be worried about that because I'm pretty sure you guys are coding cases that is well beyond April 1st by now. I don't think your office or medical records department of your hospital is coding anything prior to April 1st right now, unless you guys are really, really behind in your coding. So the next question asks, is ICD-10-CM code UO 7.1 COVID-19 retroactive to cases diagnosed before the April 1st, 2020 date? And the answer is no. The code is not retroactive. And again, I believe you should not be coding anything relevant prior to before April 1st right now. Is code B97.29 other coronavirus as the cause of disease is classified elsewhere limited to the COVID-19 virus? And the answer is no. B97.29 is not exclusive to the SARS-CoV-19 virus responsible for the COVID-19 pandemic. The code does not distinguish the more than 30 varieties of coronavirus, some of which are responsible for the common cold. Due to a heightened need to uniquely identify COVID-19, until the unique ICD-10-CM code is effective April 1st, providers are urged to consider developing facility-specific coding guidelines that limit the assignment of B97.29. And that was a code that we were pretty much utilizing up until April 1st. We were utilizing that code as a go-between until the guidance came out from the CDC as to what is the appropriate code to utilize, and the World Health Organization, all the entities involved in coming out with this new code at a rapid pace. And so I'm going to skip over this question because it's not relevant right now. I'm going to skip over that one. Let me see what this one says. Does the supplement to ICD-10-CM official guidelines for coding encoders related to COVID-19 coronavirus outbreak apply to all patient encoder types, that is, inpatient and outpatient, specifically in relationship to the coding of suspected possible or probable conditions? And the answer is yes. The supplemental applies to all patient types as stated in the supplemental guidelines. So everything, inpatient, outpatient, you name it, all cases involved, it does apply. So if the provided documents suspected, probable, or possible or probable COVID-19 do not assign code B97.29, assign a code explaining the reason for encounter, such as fever or Z20.828, which is contact with and suspected exposure to viral and communicable diseases. So that is a code of choice that you would utilize in those cases, okay? It says, the next question, the supplement to ICD-10-CM official guidelines for coding encoders related to COVID-19 coronavirus outbreak refers to coding confirmed cases in a couple of instances, but it doesn't specify what confirmation means to similar language in guidelines found for reporting HIV, Zika, or H1N1. Can you clarify whether the record needs to have a copy of the lab results or what lab tests are approved for confirmation? The answer for that is the intent of the guideline is to code only confirmed cases of COVID-19. Okay, it is not required that a copy of the confirmatory test be available in the record or documentation of the test result. The provider's diagnostic statement that a patient has a condition would suffice. Okay. Here's another next question. Should presumptive positive COVID-19 test results be coded as confirmed? And the answer is yes. Presumptive positive COVID-19 test results should be coded as confirmed. A presumptive positive test result means an individual has tested positive for the virus at a local or state level, but it has not yet been confirmed for the CDC. CDC confirmation of a local and state test for the COVID-19 virus is no longer required. So when we just got started, there was a lot of hoopla about, why are we coding COVID-19 cases as presumptive? And this is the reason why. This is the background for that. This is what was happening at the time. And so now you've seen, because of the more rapid testing, the more rapid results, now we are now able to get a more accurate reading as to whether or not that patient has COVID-19. So now we're getting immediate results now with the situation that's at hand. Okay. How should we handle cases related to COVID-19 when the test results aren't back yet? So that was a big thing when we just got started with this. I know in my facility, we hold them for a while, and there was a lot of cases that was piling up because of it. Now we don't have to worry about that because, again, we have more immediate tests that are coming out on the market that allow us to get rapid results. So in some cases, yes, because of the different labs that are being utilized by the different facilities, it could be a waiting period before you get the actual result as to what is the diagnosis for that patient. So sometimes it will come back as reading detected or negative. That's pretty much what the reading would come back to as. And then if it's detected, you utilize UO 7.1 and your claim forms to indicate that that patient do indeed have COVID-19. So that's what you need to remember there. If it's negative, then we utilize Z03.818, and that code would signify the patient was tested for that test, but it came back negative. Based on the recently released guidelines for COVID-19 infections, does a provider need to explicitly link the results of the COVID-19 test to the respiratory condition as a cause of the respiratory illness to code it as confirmed diagnosis of COVID-19? patients are being seen in our emergency department, and if results are not available at the time of discharge, are we reluctant to query the physicians to go back and document the linkage between when the results come back several days later? The answer to us is no. The provider does not need to explicitly link the test result to the respiratory condition. The positive test results can be coded as COVID-19 cases as long as the test result itself is part of the medical record, as stated in the COVID coding guidelines. So we're going to assign UO 7.1. We know that. Here's another question that was sent to so these are all questions, guys, for boy background that goes to the American Hospital Association Coding Clinic. And they pretty much are the ones that are driving the narrative, telling us, guiding us how to code. Now, I'm going to tell you, today the rule may be this, tomorrow is going to be something else. And for those who are not aware of how to look up these rules, you can go to AHIMA. AHIMA has a document on there that pretty much go over COVID-19, how to code, how to apply, and all that good stuff. And if you're not sure how to get to it, DM me and I will send you the link for it. Okay, and I'll also post the link after the webinar for this material in the presentation so everybody can get directly to it, go directly to it. Here's a question that was posed to the Coding Clinic team. We are unsure of how to interpret the new release COVID-19 guidelines in relationship to uncertain diagnosis guideline, which refers to diagnosis documented at the time of discharge, stated as possible, probable, etc. Can we code these cases as confirmed? And the answer is yes. If a test is performed during a visit or hospitalization, but results come back after discharge positive for COVID-19, then it should be coded as confirmed COVID-19. But remember, what we're doing is, if you have a case wherein a test was submitted, but you do not have the result in front of you, what your departmental guidelines should be is to hold those cases until the test results come back before you release them. So that's the practice of pretty much majority of the HIM departments that are out there, is that you pretty much hold those claims, hold those accounts until you get those results back, because CDC, everybody is keeping track of who is actually testing positive for this condition. The next question. Since the new guidelines for COVID-19 regarding sepsis just say to refer to the sepsis guideline, is that then saying that sepsis would be sequenced first and then UO 7.1 for a patient presenting with sepsis due to COVID-19? The answer, whether or not sepsis or UO 7.1 is assigned as the principal diagnosis, depends on the circumstances of admission and whether sepsis meets the definition of a principal diagnosis. For example, if a patient is admitted with pneumonia due to COVID-19, which then progressed to viral sepsis, the principal diagnosis is UO 7.1, COVID-19, followed by the codes for this viral sepsis and the viral pneumonia. And the sepsis meets the definition of principal diagnosis, then the code for viral sepsis A41.89 should be assigned as principal diagnosis, followed by codes UO 7.1 and J12.89 as a secondary diagnosis. Okay? Here's the question that troubles a lot of folks. What is the difference between code 03.818, encounter for observation for suspected exposure to other biological agents ruled out, and code Z20.828, contact with and exposure to other viral communicable diseases in relationship to COVID-19? Can you provide examples of how to apply the codes? The answer, 03.818, encounter for observation for suspected exposure to other biological agents ruled out, should be used if a patient is asymptomatic and there's a possible exposure to COVID-19 and the patient tests negative for COVID-19. Per the instructional note under category 003, codes in the category may only be used if a patient has no symptoms or signs or symptoms. Okay, so pretty much, again, as I stated earlier, if the test result comes back as negative, then this is when we're going to be utilizing this code Z03.8. Z20.82, however, 0.28, that's the code we will utilize when the patient comes back, when, well, the situation would be that the patient was in contact with someone who is tested positive for COVID-19. So that's when we will worry about Z20.828, okay? So you encounter somebody who is tested positive for it, and for whatever reason, the hospital, the clinicians decided not to test you. And I see it happen all the time. They decide for whatever reason that they're not going to administer a test. Some of the scenarios where I see is that the facility cannot administer the test. It could be an urgent care center. They don't have any testing kits. And so we are left with Z20.828 to code because the patient was not tested, but the patient did emphasize that they were in contact with somebody who has tested positive for the COVID-19 virus. In that situation, what the clinicians will do is tell that patient, you have tested positive, you need to go to a facility that can test you. And in the same breath, they will tell that patient, you need to quarantine yourself. You need to make sure that you do not come in contact with anybody else until you're properly diagnosed in that regard. Please provide guidance on correct coding when the provider has documented COVID-19 as a definitive diagnosis before the test results are available. Coding professionals in that case will query the provider. You contact the provider to ascertain whether or not this is a situation that is doable. So that's what I would do there. Okay. Hopefully you guys, if you guys have questions, please free to drop them below and in the comment section. I'll go back and try to answer them when I'm done with the presentation. Then the next question asks, please provide guidance on the correct coding when the provider has confirmed the documented COVID-19 after the test results come back negative. And then how should this be coded? If the provider still documents and confirms COVID-19, even though the test results are negative, or if the provider documented disagreement with the test results, assign code US7.1 COVID-19 as stated in the official guidelines for reporting COVID-19. The provider's documentation should be sufficient. So if the provider said that's what it is, you're going to go by the provider. Even though the test result may have come back negative, you're going to go by the provider because he or she may have seen something in the lab results that may be sufficient for them to justify applying US 7.1. Okay? So what happens when we have a patient that is tested and previously tested, and they come back now for follow-up examination to ascertain whether or not they still have the virus? We're going to apply for that person Z09, and then another code Z86.19. Those two codes will be used in combination because you're going to tell them that the patient is coming back for treatment to ascertain whether or not they still have the virus lingering in the system, followed by the Z86.19 to say, listen, patient does not no longer, have this condition. It's now a history code. Now, there is another situation out there where you have patients who are being looked at to see whether or not, you know, they can go back to work. If that's the case, there's going to be another code. I believe it's Z02.89. I believe it is. You can look that up when you get a chance, but I believe that's the code. If they intend to go back to work, you know, provided, you know, the hospital or the wherever they work at may say, listen, I need to know that you're cleared. So this is for work purposes. You're going to end up with 3 codes: Z09, Z86.19, and then Z02.89 to say, you know, this is for work purposes. Patient needs to know that, you know, they're negative and it's okay for that situation. Now, I'm going to go over some typical symptoms that is, you know, you see when the patient has COVID-19, possible COVID-19. They possibly cough, shortness of breath, difficulty breathing, fever, chills, repeated shaking, chills, muscle pain, headache, sore throat, loss of taste or smell. This list is not an all-inclusive list, but this is some majority of the symptoms that I'm seeing and that are out there as far as individuals who are coming in with COVID-19 symptoms. This is what they, you know, they typically have. All right, this is what they typically have. So yeah, so this is what's going on as far as the keeping you guys updated as far as what is going on with the COVID-19 situation. And I'm hoping this material will help you guys, guide you, and in, you know, in your daily work. And then, so what I will do is at the end of this, I will post the link for both these articles as far as where to, you know, see what diagnosis codes to utilize and how to apply them in your daily activities in the discussion forum and on medical coding bodies. And you guys can see it there and, you know, reach out to me if you still have questions. There's a lot of forums out there that you can track that where people, discussion groups, especially on HEMA, APC, people are going over this daily, have coming up with different scenarios as it relates to patient X coming with this symptom, that symptom, how should I treat this versus that. Things, so because of those moving parts, things get changed every day. Every day, this gets revamped. So just because I said this is how it is today, doesn't mean that's how it's going to be tomorrow. This is a new situation for everybody. So it's ever revolving as far as how to code each particular scenario, variations of scenario. So yeah, so that's that for that. And I'm glad you guys are here. And so right now, what I'm going to do is I am going to jump into some 3M encoder training, and I have some participants in the room with me, and I'm going to go over a couple of scenarios with them. I had 10 scenarios lined up, but not all 10 participants showed up for this practice endeavor. And so I'm going to utilize the individuals that are here, and we're going to go through some scenarios together. And they have a copy of the scenarios, and I'm going to try to share the scenarios. I'm not sure if this is going to work, but let's see how this is going to play out, and then we'll take it from there. But the intent is to go over each of these scenarios, and hopefully you guys will be able to follow along. So give me a second here. And so let's see who we have on the line. We have Carmen, Quaid, and Rosin. And so we have 3 participants right now in the room with us. And thank you for sticking around. Carmen, Quaid, and Rosin, you can unmute your mics now, and so we can get started. And while we're going through these scenarios, you can feel free to jump in and help each other out, and so you can have an idea, how to navigate the 3M encoder. So this is a training tool that I'm going to utilize to train them. So Carmen and Quade, go ahead and unmute your mics if you so choose. As long as you feel comfortable and you have no background noise. So for those who are not familiar with the 3M encoder, it is a tool that is utilized on daily in the hospital and clinicians' offices across the world, and it is utilized to code charts. So gone are the days when we only have to use the books. Now we can use an encoder to code, and that's been around for a long time now. And now there's different variations of the encoder. There is you have through code, you have Optum, you have there's different variations that are coming out every day on the market. So this is a good thing. So learning the encoder is a first step in knowing how to navigate these encoders, because learning the encoder will help build bridges as you go throughout your career. So who wants to go first here? Carmen, Quade, or Rosin? Let me show you what we're doing now. We're going to be coding utilizing first the DRG method. And for those who are not familiar with the DRG method, it's diagnostic related group. And pretty much what that is for inpatient cases, So if you work in inpatient encoders, we utilize the diagnostic related group system, and we utilize the APC, which is ambulatory patient classification system, for the outpatient setting. Okay, so we're going to be utilizing the inpatient here. Rosin, would you like to go first?
Yeah, sure.
Okay. All right. So Rosin, what I'm going to do is I'm going to assign you the option to take control of my keyboard.
Okay.
Okay. Actually, Carmen, you need to be on a laptop, on a desktop to participate. So right now, the only two participants I have is Rosin and Quade. So Carmen, you are not on a desktop, so you're not going to be able to participate right now. So if you want to get on a desktop and log back in, that's good. So Rosin, here goes the control. All right. So the first thing you want to do is hit the continue button. I already put in the age for you. All right, and select one. And so the scenario that Rosin is coding is angina pectoris with essential hypertension. So what is the main term in that statement?
Angina.
Angina, okay. What do you want to do here?
I'm looking at hypertension.
No, you're looking for angina pectoris. That's the condition, right? So what you want to do is hit the continue button. At the bottom, number 9.
Oh, here, okay.
Okay, and then here you can spell the type of angina. So number 1.
Oh, okay. Oh.
No, not HX.
Sorry.
That's all right. Let's hit the back key. It's pectoris, right?
Oh, okay.
We spelling it right? All right, can you hit the continue button? Let's see what happens. No, that didn't happen. So hit the back button again, one more time.
Oh,
Okay. Let's, do we have unspecified? And we do. And that there is a code. So what happens is that you try to type in Victorious and it didn't come up, right? So when you do it in that setting, now you know there is an unspecified code. So then you hit the back button, you go back and you click on unspecified and there goes the code. So that's your first code, okay? So the next code is to code the hypertension. But what you notice here is that you're actually under the admit diagnosis field. So just hit the continue button. And then you're going to be able to now code the angina again. You remember the steps you just went through?
oh, again?
Yeah, you're going to code it again because you're coding that was the admit diagnosis that we just did. So, right. Very good. Very good. And boom, look at that.
Oh.
See that? Because now you're in the right field. You're in the principal diagnosis field. And keep the next step. What are we doing here? Very good. And then, very good. Wait, what did you do? Go back. Go back. Just take a step back. Just essential hypertension is your diagnosis, right?
Yeah.
Okay, so what we'll be doing here? Yep, very good. And then the next step. Was any other statement mentioned? Was the patient exposed to any tobacco smoke? That's what this is asking us here. And the answer is no. And we're not coding in procedures because none was mentioned in the statement. So we're just going to answer no at number 1. And then that's it.
Okay.
And that's your coding. That's how you code that situation. All right. So hit the continue button. I want you to hit next patient. Okay. And let's also give this patient 30 years old. Okay. And 1 second, let me pull up the other scenario so everybody is on the same page. Just give me 1 second. I'm going to get back control of the mouse here for a second. Okay. And you're in control again. So let me move these out of the way. All right. Give me 1 second. I need to get back here encoder. All right. So the scenario on this one for everybody that's looking on is crescendo angina due to coronary arteriosclerosis, right and left cardiac catheterization percutaneous. So we're going to guide her through this so she can, Quaid, if you feel free to chime in and help her out as well.
Okay.
All right, so we're going to say that this patient went home. Okay, so that would be the discharge disposition. Okay, so let's make this easy so we can get to the actual principal diagnosis field. Let's code this patient as having hypertension as the admit diagnosis. So just type in HTN. Oh, that was fine too, if you want to spell it out.
Oh.
And then number 2. Very good. And so it's just hypertension, so it's just going to be unspecified. So what is the next step? Very good. And what will be the next step here? Very good. Next step here. And then finally, very good. All right. Now let me, so everybody know there is shortcuts when it comes to encoder. You can choose to just type in abbreviations if you know them. For example, with hypertension, you would have just typed in HTN, or that would have got you quicker to this diagnosis code. Okay, so we're gonna go now to the principal diagnosis because that's the one that matters. So we're gonna hit the continue button. Very good. And so now we're going to code the principal diagnosis. The principal diagnosis for this statement would be what?
Angina.
Very good. All right. So take a pause here for a second. It says crescendo angina. Do you see that?
Yeah.
Okay.
Oh, here.
All right. And it says due to coronary arteriosclerosis. Do you have that option on this screen?
Not yet.
Okay. And then again, with this, it's always going to ask you if there's any tobacco utilization. Now pause. There is a procedure, right? It says right and left cardiac catheterization percutaneous.
Oh, yeah.
Yep. So, and that would be what type of procedure? Very good. Bilateral. Any more cardiac cath procedures? Okay. There is one problem with, let's see. Yeah, there's a problem with this code. The principal procedure is fine. So what happens is the diagnosis code is incorrect. So what you're going to do for me is you're going to click on the history tab. So this is not another learning tool, because what you have coded was unstable angina. Okay.
Mm.
What we have is crescendo angina due to coronary arteriosclerosis. So click on the history tab for me.
What is it?
The history tab is going to be right. Yes, there you go. You got it. Okay. All right. So you want to look at your coding pad and to try to ascertain where you went wrong in the coding of this chart. So you can either choose to go all the way back. Remember where your angina, if you want to start there, that's a good thing about its encoder. You can pretty much go into it and figure out where you possibly could have went wrong and go from there. Okay, take a pause. What does the scenario says?
Crescendo.
Wait, yeah, but what does it, look at the complete statement.
Okay.
Crescendo angina due to coronary arteriosclerosis. Look at option 1. What is listed as a non-essential term? With, you see it?
Number 1?
Yeah. And then look at the number 1 again.
Yeah.
All right. Okay. And there was no mention of bypass graft, native vessel, transplanted heart, none of that. Okay, just give it a minute. Sometimes this 3M will kind of freeze up sometimes. Let's give it a second. Okay. Oh, see, now you went too far, so you're gonna hit the back button. All right. Now on this screen, what is crescendo angina? That's the question that you have to ask. What is a crescendo angina? Is it unstable? Is it with documented spasm? Is it other specified? Is it unspecified? Now, how are you going to know whether or not if crescendo angina is defined in any of these situations? You will hit the question mark. Ah, see? And then look at the definition.
Oh yeah, it's here.
Very good. Now hit the OK button. Right. Okay, very good. And then what am I doing on this field? Very good. All right. And then what I'm doing here? Is there any mention of hypertension or anything else? You're still on the diagnostic front. Okay. Is there any other existing situations such as history of tobacco dependence? This is one of these fields that you're always going to have to fill out when you're doing these procedure codes. Okay, so now you're on the procedures pathway. So now you're going to be coding the procedure. So remember what it is a right and left cardiac cath percutaneous. So what are we doing on this field? You want to hit the continue button, maybe? Oh, so go back, because you clicked the wrong thing. All right. Number 7. Right. And then what do we have on these fields? Do you see it stand out? Very good. And then it is bilateral. Very good. And then what am I doing on this screen? Very good. And what am I doing on this screen? Very good. And then on this screen? Very good. Now we get to the correct codes. Okay. So you were able to just code a chart worth $4,772.46. And one of these days, I'm going to go over DRG coding so you guys can be able to capture how that takes precedence and all that good stuff. But that's pretty much the weight of this chart, you know. And your CFO is going to love you because you were able to code that chart appropriately. So they're going to have no issues with you. And the DRG code for this is 287. All right. So we're going to pass the mic to Quade. Quade, are you ready?
Yes, I'm ready.
Okay, great. So give me 1 second here. Let me actually take you out of these fields so you can actually have a good setup. So Quade. Thanks for playing along, Rosen. That was good. You did a good job for your first try.
Thank you.
Yes, you did. All right. Quade, we're gonna code. I don't think we're gonna hold on 1 second because I want to jump to another. Let me start you off with something because I don't have a full participants here, so I'm just gonna try to go to something that could be easier to code, and then I'm gonna do a CPT one so everybody can see how we utilize the encoder to get CPT codes. So we're gonna do this one, and then we're gonna do a CPT one. So go ahead and do the age. Let's say make the patient 30. That's fine. And hit the continue button. So the condition we're coding in this aspect is going to be chronic fatigue syndrome. For those who are following along, that's the condition that we're coding. First of all, you want to do a disposition as to where the patient went. That's
Okay.
so that's the first thing you want to pick up, and you can select anything you want to pretty much here, but the one I tend to go with is home. The
Okay.
patient went home. All right. You can put it in the admit diagnosis field. That's fine too as well. Let's start there and see what we get. So what is your main term in that statement?
Fatigue syndrome.
Very good. All right. And that was easy. 1, 2,
Yes.
3. Okay. Now let's apply to the principal diagnosis too as well. So we're going to carry it over R53.82. So you can choose to just plug it in. So hit the continue button. And then plug it in there as well. You can choose to navigate, go back through the, go ahead, do your thing. Very good. Very good. Very good. All right, and hit the continue button. And there you go. And that is $3,253 case, DRG 948. All right, so that's how much you just brought in revenue to the hospital. Let's do next patient. Click next patient for me. All right, and just give me 1 second. Let me grab the mouse here for a second. I want to navigate to a case that has a CPT code in it. Okay. All right. So the scenario here is you're going to be coding CPT and not inpatient. Okay. So because we're coding CPT and not inpatient, you're going to have to switch the encoder to an APC product in this situation. Now, for those who are following along, when you're working in the hospital setting, what happens is that you don't have to worry about navigating from DRG to APC because of the set. Once the encoder is going to be programmed to realize the patient type that you're working on for that particular encounter. So the encoder is going to be able to pick on that whether or not you're working an inpatient case or an outpatient case. He's going to know that. He's going to be able to grasp that information based on how it's programmed. So in this situation, because we're doing, practice sessions, we have to go through that navigation of selecting APC product versus DRG product. And that's why we have to do that. So same situation. Let's make this patient 30 years old. And this time I want you to navigate over to product and navigate down to APC Finder. And remember to put in the age. You have to give her an age, yeah. Whichever age you want to select, yeah. All right, and just hit the continue button when you're ready. Very good. And now here we have bill types. Bill types are relevant because bill types are needed to capture what is a particular bill type for that particular visit. There's different type of bill types. And one of these days we'll do a billing class where I will be able to help you understand what a 131 build type is, what a 121 build type is, what a 111 build type is, and that kind of thing. And just briefly, 111 signifies inpatient hospital claim, okay? 121 is a Part B hospital claim, and a 131 is an outpatient hospital claim. So that would be your ER visits, right? That's pretty much what that is. And then so you have all those other bill types that are out there. You have bill types for SNF, you have bill type for home health, you have bill types for special facilities, clinics, and so forth. So you have different bill types. Where do these bill types go? On your claim form. This is how the encoder, not encoder, but this is how the software systems that is out there is going to be able to read exactly what type of claim is being processed in for that moment, for that time. So you submit that claim to insurance carrier. It's going to be routed via these numeric numbers that is on that claim form. That's how it's going to get routed to say this is an inpatient claim versus this is an outpatient claim. And if you have the wrong bill type, the softwares that are out there is going to be able to pick up on that, because you may have built an incorrect procedure. For example, you may have put an inpatient procedure on an outpatient claim. And so the software is going to be able to acknowledge that and shoot it back to you with denial codes, reason codes, etc., to say, listen, you did something wrong, fix it, send it back, and that kind of thing. So that's how these denial reason codes and all of those things get generated, because of how you process it from this angle. So now with that history, so you know that, now we move forward. So Quade, you need to select number 1 for me, because that's an hospital outpatient claim. Okay, and so we were right into the primary diagnosis field, so you don't even have to put any admit diagnosis on this. We're going to shoot straight for the diagnosis code. So what is the main term on this? What is the main term for the diagnosis code?
Cancer.
What type of cancer?
Colon cancer.
Very good. So go ahead. No, I wouldn't start there. Go with your instinct. It's cancer, right?
Yes.
Okay. Is it set? Wait, you were right. Go back. All right. What is it telling you here? What's it asking you?
The site, a particular area?
Yeah, the particular area. So what are you going to select? Very good. And it didn't say secondary, and it didn't say it's carcinoma, so it would be what?
Primary.
And then? Very good. And it didn't tell me any particular area of the colon, did it?
No.
Okay. So we want to do a continued list. All right, and then when you do the continue list, what you're going to do is hit the continue button. If you notice right now, the continue list button is unhighlighted. The continue button is unhighlighted. If you hit, go ahead and select continue list again. All right, and now if you notice right away what happens, the continue option is there. So go ahead, and now you get the option to select unspecified. Very good. And now you're able to select do not wish to code anymore stuff because you're good. And same likewise here, you do not wish to code anything else because that's all you got is coding cancer. All right, so now you're here and you're asked to code the procedure. So is this patient coming for chemotherapy? Is this patient coming in for appendectomy, colonoscopy, radiation therapy, resection, staging? What is happening with this patient? You can choose to do many different options here at this particular screen. what I like to do is I like to click no procedure.
Mm-hmm.
I have my diagnosis code. Then I click add procedure. And I look at the scenario and I see what the main term is. What is the main term? Hemicolectomy.
Hemicolectomy.
Very good. So that is what my main term is. So I can either one, try to spell hemicolectomy, or I can start out with colectomy, whichever. Very good. All right. And hemi means what?
Half.
Half. So it's not total. So I'm going to go with number 2. And it wasn't mentioned that it's laparoscopic. So I'm going to go with number 2. All right. And,
yes.
And is there anything else mentioned in this procedure?
No.
Okay. So I will go select what? Number 7. And was anything else mentioned about mobilization or lavage?
No.
Okay, so select number 3, and that's my code. And hit the continue button. Now, right away, everyone that's watching along, if you notice, there is no numeric dollar amount that's assigned to this particular account. There is no numeric dollar amount that's assigned to this. It's because of the fact that every facility is going to have its own specific set of contracts as it relates to these particular outpatient accounts. Every hospital and every facility will have its own set of contracts as it relates to procedures, how much they should be paid at, and all that good stuff. So every hospital, every facility will have its own contract as to with the insurance carriers to say how much should colectomy be, be paid out at, and that kind of thing. And so that's what they go by. And so, majority of them will tell you, well, we go by Medicare rules. Whatever Medicare says, that's what we're going to pay by. But there's those hospitals out there that will sit down, they will negotiate these things to the fine-tooth comb with their insurance carriers that they're going to participate with, to make sure they get the total revenue that they're looking at that's needed in order to run their facility. So they will pretty much, that's what they have the CFO for, and all those other parties that will come in play and help negotiate those terms. Okay, so that's how we run the encoder, and that's how it is pretty much played out. And I will be having more classes in relationship to this for those who like to play along. Tonight, Roseanne and Quade was the brave enough souls who stick around and played along with us. And I thank you guys for playing along with us tonight. And kudos to you guys. Thanks for participating. And hopefully this will help you to go a long mile. And I will be starting some CPT classes here shortly. And so when that happens, feel free to jump in, join, because I will, be doing a lot of this stuff along the way, doing our training sessions. That way you not only learn how to use the books, but you also know how to use the encoders, because that is pretty much what you're going to be utilizing in the field when you're out there. It's not so much the books, but the encoders. And so knowing this will get you that extra mile along the way to be able to be succinct on in your profession, and know exactly, you show your provided your company that you're working for, that you know what you're doing. So I hope this helps somebody today. And for those who would like some individual one-on-one sessions, please feel to DM me, and we can make that arrangement. With that said, thank you for joining me tonight, and have a good night, everyone. God bless you. And again, the next session is going to be the modifiers. We're going to be doing modifier training on Monday night. Monday night, we're going to be doing modifier review. And that is going to be live, not going to be live, but it's going to be via WebEx. So you have to register. This is not going to be on YouTube or anything like that, or Facebook or anything like that. This is going to be private lessons. So you need to register for the modifier review if you want to be a part of that. So we're just going to be going over some PowerPoint slides and talking about modifiers. So that's how that setup is going to be done. So that's going to be on Monday night. And then the following week, I'm going to say this now for those who are watching, for those who are registered for the CPT classes, the following Monday is when we will jumpstart the CPT classes. So the CPT classes will be started. They'll go for 2 hours, pretty much 2 hours every Monday night. Okay? 2 hours every Monday night is when we'll be having these. So those who would like to be participated in that, please feel to register. Registration closed tomorrow. Registration closed tomorrow. So make sure you register right away. Jump on the platform and register. All right, have a good night, guys. Thank you so much for good night.
Thank you.
No problem.